Welcome everyone to today's seminar. I am Suzanne Judd, Director of the Lister Hill Center for Health Policy. I'm so excited to welcome all of you to today's webinar about research assessing LGBTQ+ policies across the United States. Today's webinar is made possible by the Office of Public Health Practice, the Public Health Student Association, and the Lister Hill Center for Health Policy. Each of these sponsors is offering interesting and informative virtual events all semester long, so be sure to check out their websites and social media for updates. And now for the best part, I have the honor of introducing Dr. Billy Caceres. He's an assistant professor at the School of Nursing and the Program for the Study of LGBT Health at Columbia University. I had the honor of meeting Billy as he was interested in some work with one of the cohort studies that I get to do in the Regard study. And he told me about all the incredible work that he's doing assessing policies across the United States that are related to LGBTQ+ health. His program of research uses biobehavioral approaches to identify and intervene on psychosocial risk factors for cardiovascular disease in marginalized populations across the lifespan. He's a fellow of the American Heart Association, American Academy of Nursing, and New York Academy of Medicine. He received the 2020 National Institute of Health's Sexual and Gender Minority Early Stage Investigator Award. We are so delighted to have you here today, Dr. Caceres. Please take it away.
I think the presentation today, I'm going to provide sort of an overview of multi-level factors that influence cardiovascular health. I'm so used to saying cardiovascular health, that influence LGBTQ health disparities across the life course. And I am a cardiovascular researcher, so I think of cardiovascular risk factors commonly. So today I'm going to talk a little bit about some of the risk factors that I study in my own work. I'm going to summarize some of these existing evidence on the influence of structural stigma or structural discrimination on the health of LGBTQ persons, provide an overview of some of the methodological issues in the study of structural stigma, specifically around sort of mapping these policies across the US at the state level and also the city level, and then just identify some future directions for work in this area, which I think is really important to articulate. The first thing is I want to sort of discuss the distinction between sexual orientation and gender identity. And hopefully, I think people in this group, now that you've had a few seminars on this topic, you know the difference between the two, but oftentimes people tend to conflate sexual orientation and gender identity. And the important thing is that everybody has a sexual orientation and a gender identity. So even if somebody is a heterosexual cisgender, and by cisgender, I mean someone who's non-transgender. So if somebody is a heterosexual cisgender male, they have a sexual orientation and they have a gender identity. If somebody's a transgender person, they have a sexual orientation. Transgender is their gender identity, potentially a transgender male or female, but that doesn't mean that a transgender person can't identify as heterosexual or pansexual. So it's really important to think of these concepts as distinct, but often related. And they are dynamic and can change across the life course. But I think it's a really important distinction to make when we're talking about some of these issues, because not all of the health disparities that in this population really are uniform across groups. We see that people who might be Black and bisexual may have worse health outcomes, or if somebody's transgender and also identifies as gay, lesbian, or bisexual, they may have different health outcomes than somebody who's transgender but identifies as heterosexual. And the term LGBTQIA+ is sort of like this big umbrella term. The term that I'm using today is LGBTQ+. Sometimes I'll just say LGBTQ, but it's sort of meant to include these other populations. But the focus of the presentation today is not going to be specifically on queer, intersex, or asexual people. So when I use the following term, sexual minority, this refers to people who are non-heterosexual, which people that might have a sexual identity that's gay or lesbian, bisexual, pansexual. The term transgender refers to individuals whose gender identity does not align with their sex assigned at birth. So this may be somebody who was born female but identifies as male. That person would be a trans man or a transgender male. And then the term gender non-binary is used by people who identify as either a combination of man or woman, something else, or as having no gender. So when I use the term gender minority, this refers to people who are both transgender, who may be transgender or may be gender non-binary. So I just wanted to define some of these terms. I will use the term sexual minority and lesbian, gay, and bisexual interchangeably, but they mean the same thing. So what about the Q? So the Q stands commonly either for questioning, which is individuals who might be unsure of their sexual orientation or gender identity, or queer is the other sort of like placeholder. The Q is a placeholder for, and this is members of the LGBTQ community who may not identify with one of the previously mentioned identities. And this is a term that's commonly used among, I guess, Gen Zers is what we call it. So people that are like, people around my age don't necessarily use it that much. But I think what I see is a lot of students that I work with tend to identify more as queer than they do as gay or lesbian or another identity. So a little bit of background. So the latest estimates from Gallup indicate that about 5.6% of the population in the United States identify as LGBTQ, one of those identities. I don't remember specifically what the breakdown was, but what's interesting is that if you see here, as time moves on, more and more people in younger generations are identifying as LGBTQ, with about 16% of Gen Zers identifying as either lesbian, gay, bisexual, transgender, or queer. So as we move on, I think that these LGBTQ issues are only going to become even more important to think about, and particularly how these structural policies impact health. So I oftentimes hear from people saying things like, and I'll talk about it a little bit later, of saying things like, well, same-sex marriage was passed, so there aren't any more LGBTQ policy issues, right? Because same-sex marriage passed. But it's sort of showing a naivete and a lack of understanding about all the other policies that potentially influence LGBTQ people. And I argue today that, or I usually argue that some of those policies are LGBTQ specific, but a lot of them actually are not. So the interesting thing about health disparities really in general is that there's really no biological basis for most of the health disparities that we see. And this is true for LGBTQ people as well as racial ethnic minorities and other groups, right? These are based on social determinants, things like discrimination, violence, and poverty. And all of those factors have been associated with worse health outcomes among LGBTQ adults. Things like poor mental health, substance use, HIV, and other sexually transmitted infections, and even gynecological cancers among lesbian and bisexual women in particular. So if anybody really wants to sort of like do a deep dive on LGBTQ disparities, I recommend looking at one of or both of these reports. This report to the left was released in 2011 by the Institute of Medicine, which is now called the National Academy of Medicine. And this report really was a first attempt to sort of comprehensively detail some of the disparities that we're going to talk about a little bit today. This newer report from 2020 sort of took a more like resilience focused aspect and focuses more on promoting wellness and resilience promoting factors. But the interesting thing is that if you look at both reports, there are areas and sections that were not in the 2011 report that are now in this new report because of the advances we've made in certain areas. So one of the areas which I'm excited about because I'm a cardiovascular researcher is cardiovascular disease. There's now a separate section in the 2020 report that really talks about what we know about cardiovascular disease. So LGBTQ research is really moving really fast and expanding, and it's sort of growing into new areas. So it's a really exciting time to sort of talk about this research area and talk about where it could go, particularly around sort of policies. So HIV prevalence is one of the most well-known disparities among LGBTQ populations, particularly among men who have sex with men and transgender populations, with transgender women having about a 14% prevalence of HIV compared to the US population, which is about 0.3%. And we see similar disparities among men who have sex with men over the age of 13, where we see that over time, the incidence of HIV remains higher among Black and Hispanic individuals. And this data from 2010 to 2018 has shown that actually the incidence among Latino men has actually increased. So it has had a significant increase, sorry. So some of the disparities that I think about a lot of the time are tobacco use as a big risk factor for cardiovascular disease. And we see that LGBT adults are more likely to report current and lifetime tobacco use, and that past year discrimination has been identified as a predictor of those of tobacco use or smoking among LGBT adults. In the US Trans Survey, which is this large survey of about 4,000 trans people, they found that discrimination was associated with cigarette smoking and also dual cigarette use, which is the use of both cigarettes and e-cigarettes, I believe. And visual nonconformity as another sort of social determinant was also associated with all forms, elevated prevalence of all forms of tobacco use. And visual nonconformity is a transgender person's, and the way that they conceptualize it in this study was the transgender participants' perception of whether or not they were visually non-conforming. It's basically sort of the mismatch between gender identity and their gender expression, or how other people perceive them. And that was shown that people who identify, let's say, as a transgender man, but are frequently misgendered or feel that they don't actually look like a transgender male to other individuals, actually reported higher tobacco use. So we're starting to understand how these sort of social determinants like discrimination, visual nonconformity might influence health outcomes. And this is just one example. So one of the outcomes that I think about a lot is body mass index, or obesity. And research overwhelmingly shows that lesbian and bisexual women have higher prevalence of obesity. My dissertation research actually showed that bisexual men were 69% more likely to meet criteria for obesity than heterosexual men. That was analyzing data from the National Health and Nutrition Examination Survey. Gay men either have similar or lower rates of obesity than heterosexual men. And then research on elevated BMI in transgender adults is generally mixed. It tends to focus on transgender individuals that are on hormone therapy, right? So gender affirming hormone therapy, either masculinizing or feminizing hormones. So most of the research has actually shown that transgender men have some elevations in BMI, but it's likely due to the fact that when they're taking masculinizing hormones, that their muscle mass also increases. So it's not necessarily that their body fat is increasing, but it's just a muscle mass increase. And then blood pressure for me is a big thing because it's probably the most important risk factor for cardiovascular risk. And evidence to date has really been conflicting, but a recent meta-analysis by Lopez et al., which was just published in the fall, found that more recent studies suggest that gay and bisexual men have higher blood pressure than heterosexual men. And that bisexual men, this is also from my dissertation, bisexual men are 2 times more likely to meet criteria for hypertension than heterosexual men. And this is objectively measured, actually measuring people's blood pressure rather than self-report. But overall for transgender people, findings from reviews indicate inconclusive findings related to elevations in blood pressure that might be statistically significant, but I think we all know that there's a difference between statistical significance and actual clinical significance, and that generally the statistically significant findings really aren't that clinically important, or have been deemed not to be that clinically important among transgender men in particular. So really, when I think about, and I sort of maybe spoiled you a little bit because I talked about discrimination or did a spoiler, is that stigma is really a fundamental cause of health disparities. And you can think of stigma as sort of, it's this devaluing of individuals based on a social construct or characteristic, right? So things like gender is a social construct, race is a social construct, but individuals in society, and particularly in our country, I think that we can all agree that there are certain individuals or groups in which they're just like navigating everyday life is probably a little bit harder just because of who they are, right? So just because of attributes that they can't necessarily change, their race, their gender, their sexual orientation. And I think that that's sort of, when we're thinking about stigma, well, I think it's really important to think about for LGBTQ people that there's multiple sources of stigma or adverse experiences, and one of them is violence. And LGBTQ people tend to experience more violence than their cisgender heterosexual peers in childhood, things like physical and sexual abuse, and that's even compared to their heterosexual siblings. So even when they're raised in the same family, they seem to experience greater violence. And we also know that there's a higher prevalence of interpersonal violence among LGBTQ adults, particularly bisexual women having much higher rates of domestic violence. And then this, I am constantly like shocked by some of these statistics, but last year marked the worst year on record for transphobic violence, with 44 trans women murdered in 2020. And actually, I think that this is probably an underestimate because I think these are the individuals that we actually found their bodies, unfortunately. There's probably other individuals who are missing that likely were also murdered or being held to captivity or whatever other else horrendous thing could have happened to them. But the thing here to think about is that it's really the groups that we see adversely or mostly affected by sort of even transphobic violence are Black and Latinx populations. So even within a community that's particularly vulnerable, that the vulnerabilities aren't all uniform. And then poverty is sort of a really interesting social determinant that you wouldn't necessarily think like, oh, well, LGBTQ people might have higher rates of poverty, but the data does indicate that. So these are data from the Behavioral Risk Factor Surveillance System from 2014 to 2017. And you can see on the map, the states that are in orange are states that found these researchers found that LGBT people had higher rates of poverty. So they had 35 states, and 22 of those 35 states showed that LGBT people were more likely to live in poverty than heterosexual cisgender adults, which is a rate of 21.6 versus 15.7%. But then when we look at within the LGBT population, who actually experiences higher rates of poverty, it's bisexual men, it's bisexual women, it's transgender people. And then when we actually look at it by race, almost 40% of Latinx LGBT people live in poverty, and about a third of Black and American Indian or Alaskan Native LGBTQ people live in poverty compared to their white peers, which is about 15.4%. So this estimate for white LGBTQ people is actually very similar for what it is for the entire cisgender heterosexual population. So even just these like small differences, when we start to break down the populations and not just think of them all as one group, we see sort of these clear differences in not only their social determinants and the adversities that they're exposed to, but in their health outcomes as well. And the reason why poverty is really important is because socioeconomic status or socioeconomic opportunity is largely determined by in some cases, by policies. And not necessarily some policies that might be specific to LGBTQ people, which I'll talk about, I think, in a second, but also policies that might not be specific to LGBTQ people, but that might disproportionately advantage LGBTQ people when we promote policies that actually are more equitable or have more equitable distribution of resources. So healthcare utilization is also very interesting. We see similar rates of health insurance among LGBT people, but LGB and gender non-binary adults are much more likely to delay care because of cost reasons and because of other reasons. Things like being unable to take time off from work to schedule an appointment, not having adequate transportation to go see a healthcare provider. And transgender adults, I hope this isn't a surprise to people, are much more likely to delay care due to fear of discrimination. It's estimated that between 50 to 70% of transgender people have experienced discrimination from a healthcare provider in the past. So we could see why a transgender person would avoid seeking care, because they're afraid of being treated differently, of potentially receiving inferior care, depending on who their provider might be. And these are some additional considerations. I'm not going to go into detail about it, but these are all things that influence the health of this population. And some of these can actually be regulated or mitigated by actually enforcing different policies. Things like the assessment of sexual orientation and gender identity in clinical settings, or even ensuring that healthcare providers have adequate training or education about LGBTQ health issues can all sort of be improved if we had policies at the institutional, local, or state level. So the minority stress model, hopefully you've heard about this before. I don't know if other speakers this semester have talked about it, but it's the sort of prevailing evidence-based framework to understand LGBTQ health disparities. And what it posits is that LGBTQ people experience unique stressors due to things like marginalization, and that these are additive, so in addition to general life stressors. So right, we all have work stress or financial strain or get into arguments with our parents, but for LGBTQ people, all of the general stressors of everyday life are then compounded by these minority stressors. And some examples of these include at the individual, interpersonal, and today what we're talking about, the structural level. So at the individual level, some examples are expectations of being rejected or expectations of discrimination. Interpersonal level is what we commonly think about. These are prejudice events or interpersonal experiences of discrimination, but also some of that violence that I was talking about, the high rates of violence, might actually be bias motivated violence, where LGBTQ people experience more violence because they're targeted, because of their perceived or actual sexual orientation and or gender identity. And then at the structural level, we can think of things like laws, anti-discrimination laws and hate crime laws. So some of the research has shown that minority stress is associated with a number of health outcomes, with multiple forms of discrimination associated with worse mental health outcomes. Gender-based discrimination has been associated with depression among transgender people. And transgender people, this just speaks to the importance of family support. Transgender people who report family rejection have increased odds of having attempted a suicide at some point in their lives. And we see similar things for substance use, for cigarette smoking and heavy drinking among lesbian, gay, and bisexual adults, and also drug use among gay men. And among transgender women, exposure to discrimination has been associated with higher odds of current tobacco use and also unsuccessful smoking cessation. So even when people are attempting to quit smoking, they are less likely to actually maintain that. And some of the research around physical health, really considerably less research on the impact of minority stress. And this is one of the areas that I do a lot of work in. But I couldn't think of enough to actually like condense it into a nice slide with findings for you. So what is structural stigma or structural level minority stress? So this could be thought of as societal level conditions, cultural norms, institutional policies that constrain the opportunities, resources, and well-being of the stigmatized. So it's not specific just to LGBTQ people, but to stigmatized populations. So we could think of this also for racial ethnic minorities, people with disabilities, and other populations that might be stigmatized. And there's two common methods in the literature for sort of conceptualizing and measuring structural stigma. One is policy analysis, which is looking at those state level or city level policies, which is what the focus really of the rest of this presentation is about. And then the other one is aggregated measures of social attitudes, where you actually survey people. Gallup, or one of the big survey companies, will survey people in a particular state and ask them about their opinions about same-sex marriage or same-sex adoption. And that sort of, they'll sometimes aggregate that measure to sort of indicate in that state, this is sort of the support for this policy for LGBTQ people. So employment discrimination laws is just one aspect of this. So this map reflects what the employment discrimination laws in the US were in June 14th of 2020. As of June 15th of 2020, the Supreme Court ruled that it's illegal to discriminate against, to have employment discrimination against LGBT people based on their sexual orientation or gender identity. But this is what it was before that. And you can see here that the states in dark green were the states that actually had protections for LGBTQ people. And these other states had varying percentages. And these percentages indicate that there might have been local ordinances at the city level potentially that did have employment non-discrimination laws. And then you see these three states here actually have laws that prevent the passage of local non-discrimination laws. So you see that in Arkansas, Tennessee, and North Carolina, there's actually a law at the federal level that prohibits local employment non-discrimination laws. So if we think about, and this is some of the work that when I talked to Dr. Judd, this is what I'm about to present is sort of what we've been working on. So one of the things I've been really interested in is generally the research on structural stigma, which I'll discuss a little bit more in a few slides, has generally focused on one policy or a number of policies occurring at one point in time and how that's associated with the health outcome at that point in time, or maybe the year later. And I'm really interested in sort of like, how can we actually create a database a database of these policies over time, the last 20 years, year by year, what were the policies in that year, as a way to help us as health outcomes researchers sort of be able to link these data to things like the behavioral risk factor surveillance system and other data sets that have information at the state level. So in 1999, there were about 5 states that had employment non-discrimination laws. By 2009, that number about doubled. If you look at 2019, there really wasn't that big of a change between 2009 and 2019. But then in 2020, Supreme Court ruled that it was illegal. And I think one of the things is, I'm only going to highlight this, and I hope you don't think that I'm picking on you, but if you can see here, and I think it's true for the next 2 slides, Alabama did not have employment non-discrimination laws. It wasn't until the Supreme Court federal ruling came about. So actually, it'd be interesting, and I'll highlight Alabama because I know that's where you all are. So that's the only reason. I don't mean to pick on you. I'm just highlighting it because I know that's where you are. So for same-sex marriage, the first state to pass the same-sex marriage law was Massachusetts in 2004. By 2009, we actually didn't see that much growth in that. In the early 2000s, though, look at the big jump between 2009 and 2014 of different states that had passed same-sex marriage laws. And then by 2015, it was in the entire country at the federal level. But again, you see that Alabama and some of the neighboring states really are among the last to really end up passing these laws. They generally don't come from the state level. They're sort of coming at the federal level a lot of the time. And then hate crime laws. So these are crimes that protect LGBTQ people from they provide them a legal recourse if they are victims of hate crimes. In 1999, there were about 5 states. 2005 saw a huge jump in the number of states that protected LGBTQ people from hate crimes. 2019, really not that big of a difference between 2005 and 2019. You see again, Alabama did not have those policies. And even now to date, it still doesn't exist because hate crime laws are still regulated mainly at the state level, not at the federal level. So there's about 20, I think it's 24 states that still do not protect from hate crimes based on sexual orientation and or gender identity in this country. So we could think about how some LGBTQ people might not want to even report hate crimes because they feel that they're either it's not going to be taken seriously or nothing's really going to come about it in some of these states. So public accommodations is another set of laws. These are laws that regulate public settings, restaurants, police stations, hospitals, actually not hospitals, health clinics count as public accommodations. And you can see here, and this is, I think, accurate as of 2020, only about 22 states actually provide full protection from discrimination in public accommodations. Again, this is like a police station. Somebody going to report a crime in a police station could be potentially discriminated against. And we can think this, and again, this goes back to the point of how do we expect people that are LGBTQ, particularly trans people, how do we expect them to seek healthcare on a regular basis when they feel they're going to be discriminated against, or to even seek help from police officers and other sort of like professions that are supposed to be helping professions when they really don't have necessarily legal recourse if something were to happen to them in those settings. But you see here, Alabama is about 4% of jurisdictions in Alabama actually have public accommodation laws that protect LGBTQ people. In Kansas, it's about 30%. So there's really big variation, even in the states that don't have these laws at the state level. And then there's, this just happened, I think, in the past week, but this gay or trans panic defense, which is when an individual commits a violent crime against an LGBTQ person and uses the gay or trans panic defense, saying that they just could not control themselves. And it's sort of like this like momentary insanity sort of like defense that Virginia just banned it. But I actually was very surprised about this. I didn't find this out until the last week. There's only 12 states that ban this as a defense for anti-LGBTQ violence. 12 states. And most of those states are either on the West Coast or the East Coast. Not many states in the middle of the country except for Illinois. So I think that this particularly leaves a lot of LGBTQ people vulnerable to sort of being victims of crimes or violence without actually having much protection potentially from the legal system. And then this has gotten a lot of attention, sort of these anti-trans bills. So in 2020, 82 anti-trans bills were proposed, which is the largest in history compared to the previous year, which was about 79. And one of the states that's gotten a lot of attention in the last week for this anti-trans youth bill that seeks to ban healthcare for all trans youth in Arkansas. So this is from last week. The state legislator passed this bill that banned healthcare for trans youth. Then on Monday of this week, the governor in Arkansas vetoed that bill. And then yesterday, the state legislator overrode the governor's veto. And now it's going to continue to be, it's going to other courts, and ACLU has vowed to prepare litigation to fight against this. But it's sort of these, we've seen over the last 5 years, right? So did passing same-sex marriage fix everything? No, because what we've seen is all of these other bills now creeping up as ways to sort of, I don't know if I should use this language, but it's to eliminate, eradicate, get rid of LGBTQ people, particularly trans people. And then we have similar bills, so Arkansas, South Dakota, and then your great state of Alabama, a similar law that would, and I don't actually know what the status of this is, but this HB1 SB10 would make it a felony to provide gender affirming care for trans youth. And everybody's really obsessed about trans girls being in sports with cisgender girls. It's like an obsession that people have, and it's like they harp on this. It was like the bathroom bans that happened a few years ago, which people are still really obsessed about. But there's really no like scientific evidence to indicate that actually they do have an unfair advantage for a majority of sports. It's just people sort of like harp on these issues. And it's really, I think it's really it speaks to sort of the political mobilization of certain groups in this country, probably particularly religious groups that are religiously affiliated, where they've sort of, these issues have sort of become like the boogeyman that are going to infringe upon their way of life, or the way of life of their children, God forbid. So it's sort of like really interesting. And as somebody who's not transgender, I think a lot of these policies that we've talked about are sort of state level, but I'm in New York, which is a state that has a lot of really good protective policies. But we often think of, how do policies in your state impact your health outcomes? But I would argue that if I was a trans youth in a neighboring state or in a different state, that knowing that a state in my country was trying to pass these laws for kids like me, that would also have an impact on my mental health. So I think that there's this sort of like, we have this blind spot about how these policies also influence other people. And forget about being a trans youth in a different state. Like, I'm not trans, but I just get chills whenever I talk about these policies. And I'm sure that they influence things in my everyday life about like my motivations to write a paper or write a grant, because I'm too stressed out about the state of how things are going for trans youth. And then for specifically for LGBT youth policies, there's some protective policies, these anti-bullying policies, which you see in the dark green states on the left. But then there's also these negative policies, which are the Don't Say Gay regulations, which I think exist in about, I forget how many states, but it's states in which like there isn't the curricula, it's banned to have any gay content in the curricula or even say the word gay or LGBTQ. So it sort of decreases the visibility for little queer kids to actually see themselves reflected in their curricula. So measuring structural stigma, and this is sort of where we get to measurement issues, has been done in a number of different ways. So I'm going to provide some resources for people that want to learn more about this, but the Movement Advancement Project is a wonderful organization. It's been around for about 15 or 16 years, really mapping these policies on I think they map them every 5 years and they release a report about this. So if you see here, what they do is they take about 40, I think it's between 30 to 40 different policies that are LGBTQ specific, things like adoption laws and rights for same-sex partners or health insurance for same-sex partners. There's HIV criminalization laws, and they create a tally for them every 5 years or so. And you can see here that there are different categories, from a negative to a high overall category, which most of the United States actually is not in this high or even the medium category. Most of it is actually in this lower negative category. And the policies are tallied by sexual orientation, which you see here, by gender identity, and then they're summed to create a cumulative score that actually is the total influence of these sexual orientation and gender identity related policies. So this report is actually a really interesting report. I recommend that people read it. I think it's if you're really interested in this topic, but you can see here, this was the state of affairs for policies in 2010, a lot more red than in 2020. So things have sort of shifted a little bit. And you can see that the overall tally score across the US increased from an average of 3.1 to 13.7, indicating more protective policies nationwide. And this national average puts us in the fair category, which is this sort of like middle category. So we're not in the medium, we're not in the high. And I'll skip this for now. But then the other thing that we've seen a proliferation of is these religious exemption laws, where they exempt certain service providers, including healthcare providers. And as a nurse, I think about this a lot as for healthcare providers. It actually, they can use the defense, or they can refuse to actually provide care for people, or refuse to work with LGBTQ people if they state that providing that care would conflict with their religious beliefs. And what we've seen is really a proliferation of these laws, where 10 years ago, only one state, or 11 years ago, only one state had religious exemption laws. Now 13 states have these laws. So this is, I think, sort of been a reaction to the same-sex marriage, the employment discrimination laws that protect LGBTQ people that we've seen over the past 5 or 6 years. And then you see here that there has been a significant change in terms of these religious exemption laws, where it's actually been getting worse nationwide. And then the Municipal Equality Index is actually a really cool resource to the Human Rights Campaign, where they actually it's not at the state level, it's actually at the municipal or city level for about 500, and it's over 500 cities in the United States. And they actually release this every year. And these are some of the policies that they include. It's things like, do they offer trans inclusive health benefits for city employees? Do they offer supported and targeted services for the trans community? So at this level, if you have data sort of at the city level and you want to examine some outcomes, you could actually probably use these types of data that are a little more granular than the MAP or the Movement Advancement Project data, which is at the state level. And then this measure of structural stigma was developed by Mark Hatzenbuehler, who's probably the most prolific researcher in this area of structural stigma. And what he created was this index that combined state level policies, which I list here, the density at the state level of same-sex partner households, and then also those public opinion polls that I talked about regarding LGBTQ public opinion around hate crimes or same-sex adoption. And so there's a number of different ways of measuring it, and people have used different sort of like ways of measuring structural stigma, which I think is helpful, but also it makes it difficult to sort of condense the literature and sort of really understand what type of structural stigma is actually influencing health outcomes, or what's the most important type of policy that we should be considering. So some of the evidence that I highlight here is that civil union legislation in Illinois was actually associated with lower depressive symptoms and alcohol use among sexual minority women after it was passed. And the legalization of same-sex marriage in Massachusetts in 2004 was associated with a 14% reduction in both depression and an 18% reduction in hypertension among gay and bisexual men in that state. And then I'm not going to highlight all of them, but this study found that state level policies predicted both tobacco and alcohol use in lesbian, gay, and bisexual young adults, so ages 18 to 25, but that the timing of when people were exposed to that policy was really important, with actually comparing timing in high school versus college age years, where high school years were actually more predictive of alcohol use than the policies in college years. So some of the projects that we're working on right now, and this is sort of why Dr. Judd invited me to talk about this today, is we've been conducting these literature reviews. And really, I can't say that this is like my main focus. It's the focus of the PhD students that I work with who are so passionate about this issue. And we're in the process of conducting 2 different reviews, and I'm going to talk a little bit about the findings of one of them today. And then we've done some analyses of the BRFSS data, which has state level data, linking those LGBTQ state level policies with different health outcomes. And some of that work we're hoping to present in the fall. And then long term, it's really thinking about how do we map these policies, not by every 5 years, but by every year. And should we do that at the city level? Should we do that at the state level? It's sort of unclear sort of what level of influence is most important. But it's really important, I think, to create these longitudinal data sets that have these policies to permit linking of those policies to actual health data. And I think it's also important, I'm not a legal epidemiologist or legal scholar, so I think I definitely need to collaborate with people that have expertise in that area. Sorry, my dog, I think, disagrees with me. So he might bark for a little bit, sorry. So I think it's really important to think about interdisciplinary collaborations. So this review of the literature, we conducted a review of literature looking at structural stigma and mental health, and we found 12 different studies that actually measured stigma in multiple different ways, which made it really hard to sort of like do some sort of like quantitative analysis of these data. So we actually just did a qualitative analysis. What we found was that actually, like, although these policies, a lot of people think they are really important, right? And we know that these supportive policies are helpful for people's well-being and they're important to sort of support and pass. What we found is that in general, the literature is quite mixed, with only 50% of the studies that we looked at finding significant associations between structural stigma and depression. Overall, the evidence varies, and it's not even varied by whether or not you're looking at same-sex marriage equality or a different policy. It's a little bit all over the place. And what we found similarly for anxiety was sort of the same thing. There were 7 studies that had examined structural stigma and anxiety, and only 4 of them had found a significant association between those 2 things. So I think what this gets at, and hopefully this might be controversial, but I think, are protective policies enough? And I don't think they are. And this, I think that our best sort of like evidence of this is the Civil Rights Act of 1964. Do we still have racial ethnic disparities and inequalities? I would argue we do. We have them for police brutality. We have them for maternal child outcomes. We have them for COVID with increased deaths, increased prevalence of COVID infections. So I think that although we've talked about these policies as sort of like passing these policies, they're really important, but they're not necessarily the be all end all. And I think it's really important for us to understand what's actually happening to people in their everyday lives. So really thinking about from the individual level all the way up to the structural level is particularly important. So there's other policies that actually disproportionately help LGBTQ people. The Affordable Care Act has improved access for healthcare for LGBTQ people in particular. But they still report continued issues affording and accessing care. And this, there's been a lot of conversation about repealing the Affordable Care Act, but it would really, and this article is really interesting, but it would really have devastating impacts on the LGBTQ community. And many people that have access to healthcare now would actually lose that. And then the CARE Act, which is a sort of this policy around caregiving that makes hospital, if somebody's in the hospital, it makes it so that healthcare providers in the hospital actually have to identify a caregiver and provide information and knowledge to them. This policy might also help LGBTQ people, particularly older adults, because they're actually going to have their caregivers and their partners recognized formally by the healthcare provider as somebody that they actually need to engage with in conversations. But whether or not this actually happens in practice is a totally different story. And then for this report from 2015 about the financial penalty of being an LGBT woman in America is really interesting. But again, it's not just about passing LGBTQ related policies, but things like parental leave and affordable childcare laws disproportionately would help LGBTQ women actually achieve some financial parity with their peers, particularly their male peers. And there's this call from NIH now on National Institutes of Health on structural discrimination, structural racism and discrimination, which is great. But I think if you see by institute how many awards are going to be given, this is not enough, right? So now all of a sudden we all care about structural racism because we all woke up to the fact that Black people and other groups experience really bad, have really bad experiences just living their everyday lives. And I really argue, and this might be controversial, this is just not enough, that really we need to be doing more to really examine these differences, investing more money and effort into these things. And although this is great, I think that there's been some criticism around some of these calls for these types of grants because they have a very fast turnaround. And the argument has been, who is actually going to benefit from these? Is it going to be people of color? Is it going to be women? Or are we just continuing to perpetuate the disparities in funding that we already see? Are we going to continue to see people from majority groups making their research careers on the backs and using the data from people of color? And I think that that is a valid argument and one that I don't think we can really minimize at all. So that's my soapbox spiel, I'm sorry. So there's methodological concerns in the field around structural stigma. What level of analysis is appropriate? Do people actually enforce these laws when they're passed? The timing of the law is important. If they pass a law in 2016, how long does it take to actually see the health effects of that law? There's been limited investigation overall of multi-level stigma, right? How does interpersonal discrimination interact with structural stigma? And then this larger policy context, caregiver policies and other policies are also important to consider. And then lastly is, what is the importance of LGBTQ people being aware that they live in a state that has good protective policies or not protective policies? Does that influence health and health outcomes? Well, it's not really clear based on the literature if that's actually an important thing to consider. So for future directions, I think we need to develop and test measures of structural stigma, more validated measures. Many of these measures haven't actually been validated. We need to examine LGBTQ policies within the context of broader health and social policies, examine the mechanisms that link these structural stigmas to health, and investigate both the independent and synergistic effects of multi-level stigma, as well as supporting interdisciplinary collaboration. So overall, the study of structural stigma and health in LGBTQ people is nascent, but significant advances have been made, particularly over the last 10 or 15 years. Mapping these LGBTQ policies is complicated because just because the policy was there in 2016 doesn't mean it's still there in 2017, and it doesn't mean that it's actually enforced. And then measurement concerns need to be addressed in future work.
That was really fantastic, Billy. It's such a huge introduction to the breadth of policies and research questions that are out there. I want to start first with a question that we've had from the group before we got here. One of the things we're actively trying to do at UAB, we have the funds to create an endowed professorship in LGBTQ plus health studies.
Mhm.
And so we're recruiting right now for this position. What do you think as an academic professional we should expect from someone in this sort of position? Yeah, it's deep.
You should expect in terms of their area of expertise or what they would bring to your school.
Bring to the school, also area of expertise, work with the community. You know, I think it's so new. We did a lot of research looking at other universities, and there aren't positions like this out there.
Mhm.
So we're very interested in trying to be thoughtful about what would be the types of research, what would be the engagement in the community, just in general. No
Yeah.
right answer, obviously.
Yeah, you know, I did think about this. I was sort of like primed for this a little bit. So I did think about this. So I will say that there are two parts to that question. One is with the expertise that maybe you should be looking for. And two is what I think sort of like a senior level person in this area of research would bring to your school. So for the first one, I think that it's really important, as you can see, and much even of my own work, I'm guilty of this, has really focused on sort of describing these differences and identifying some factors that maybe lead to differences in health. But we really, I think, need to move beyond that to think about how do we create interventions and how do we use implementation science and community-based participatory research techniques to actually create and disseminate interventions to the community, work with communities to actually create interventions that people will want to engage in, right? I think that that's really sort of, we generally like exist in these silos from community members, and I've been guilty of that. And one of the things I think that you should look for in someone is whether or not they have had community advisory boards on their studies. Have they worked with community members? Are they considering the community members' voices in not only the design and interpretation of their findings, but actually the dissemination of those findings? I think it's really important. I think often in academia, those things aren't necessarily valued, because like valued is like getting grants really quickly, and sort of working with communities does sort of prolong timelines, if you will. But I think what would be really helpful is to find someone who can sort of bridge that gap and take us into the next stage of actual evidence-based, both public health and clinical interventions. And what you would expect for that person to bring is sort of what I said, but I think also I often find that when people think of someone as an LGBT researcher, they only think of someone as an LGBT researcher. But I hope that what I tried to do a little bit in my presentation was show that a lot of these structural determinants, or really all of these sort of like minority stressors, operate in similar ways for different minority groups, so that people who are LGBT, quote unquote, LGBT experts also bring vast expertise that can be used to study other groups and other populations.
That's great. We actually had one of the attendees that had a similar question about research. You mentioned a lot of about the stigma that exists along the way at the structural level. What are your thoughts about the role of healthcare delivery in organizations and providers in the complex relationships? And really, what are the unanswered research questions in specifically this healthcare delivery piece of research?
So, I mean, and I used to think about this a lot because I worked as a nurse for 9 years while I was finishing my PhD. And I used to see sort of things related to LGBTQ patients that were good and things that were not so good. And so I think this is a really good question, and it gets to the enforcement issue, right? So like, even if you have a policy at the institutional or state level that prohibits somebody from discriminating against an LGBTQ person, how do you prove that they're actually providing equitable care to all patients, right? They're providing evidence-based care to all patients. It's sort of really hard to prove. And I think one of the big issues has been that we generally across the health professions, and it's also been true, I think, in public health curricula, but certainly among physicians and nurses and physician assistants, is that we don't get much content about LGBTQ health. So then we're throwing people into clinical practice without really understanding much about the needs of these marginalized groups. And oftentimes people might come from a background where you aren't from a marginalized group, and it's hard for you to understand sort of like how to approach patients. I think there needs to be more done within healthcare institutions to make sure that providers understand LGBTQ health issues, but also that this type of bias in care will not be tolerated. And that's sort of like what we actually need in healthcare.
So we had a speaker earlier in the semester, and we asked him the same question. and I'll give you his answer first, and you can see what yours might be. You know, what are the things we can do with healthcare delivery right away to make a difference? And his answer was change the intake forms, allow for pronouns, let people tell you what they want to be, like how they want to be addressed, Mr., Mrs., however it is. So what's your opinion? What's one thing we could do today to change that healthcare delivery to make it more inclusive and make more folks in the LGBTQ plus community feel welcome at the doctor's office?
Yeah, and I get asked this question a lot and I talk about it a lot, but I think intake forms is one thing. I think that not assuming people's pronouns, not assuming what the sex or gender of their spouse or partner might be, using sort of neutral language, I think is one thing. And you know, when I was working clinically, the thing that the people had the hardest time with trans patients was getting the pronouns right. So it's like, if you can't figure out the proper pronoun, then just call the person by their first name. That's fine. It's a perfectly adequate way of referring to a patient if you're really having issues with that. And I think that it's a lot of times people just don't have a level of familiarity with it. So I think that improving sort of education for providers when they're in school, but then also providing continuing education for providers is important for LGBTQ health issues. One of the big issues has been now with the electronic health records, every electronic health record has to have the capability of assessing sexual orientation and gender identity. But whether or not providers actually implement that is an entirely different story. So I think that one of the really tough things is that providers think that, well, if I ask about sexual orientation and gender identity, people will be offended or people will not want to answer it. But yes, there might be patients that might be offended by asking them, what is your sexual orientation? But for LGBTQ patients, it's affirming. They actually feel like they're seen and heard and their identities are valued. And I think that really goes a long way. I mean, there's other sort of like not silly things, but like little things that institutions can do, like even showing I think about nursing homes often have these images of older adults in the hallways doing stuff like, I don't know, in a field or in a park. Just by showing two women or two men together, they might not be a couple, but it makes older adults that are LGBTQ potentially think like, oh, that might be a same-sex couple. This is a place that might be potentially inclusive. So there's just little steps that institutions can make. But I think that overall, there does need to be sort of an overhaul of how we provide care to LGBTQ patients. I've often said that, you know, we have these baby-friendly designations for hospitals for maternity care. Why don't we have an LGBTQ-friendly designation where it's actually promoted so that patients know, like, hey, if you're LGBTQ, our staff here are trained in how to care for these issues. We care about you and want to affirm your identity. And if anything happens where you don't feel like that's the situation, then you can report it to these people. I think that's the kind of things that we need at the sort of clinical level.
You've also got folks in the chat that are very interested in following up with you on research. Do you mind if we share your email address with folks who are in touch with you?
Yeah. Oh, I was just reading Stephanie Perry's comment about the Healthcare Equality Index, which, yes, the Healthcare Equality Index is another great resource by the Human Rights Campaign, which actually, I think it's every year, maybe every 2 years, they actually give scores to health systems around the country and health clinics for their inclusiveness of LGBTQ issues. And that's also a way that LGBTQ people can find institutions or clinical settings where an outside organization has said they're doing the right things to actually care for LGBTQ people. And they might include things like whether or not they have employment non-discrimination for their employees at the hospital. And that simple things like that. So it's not just about how they care for patients, but also their employees. So it's interesting.
Another attendee, I guess you've got the chat as well so you can see it, but noticed increasing trends in LGBTQ plus across generations. Any explanations for that in the short period of time?
Yeah, I mean, that's great. That's anonymous attendee. That's a great question. But I think that there's a number of different explanations. I think that despite the fact that we still have a ways to go, there's been vast improvements in the acceptance of LGBTQ people and people's understanding of it, right? So if you can think now little queer kids are growing up having a gay uncle or a trans aunt. And that, I think, does a lot to educate families. I think there's just been greater acceptance at the family level, even at society level, even though things could be better. I think that's part of it. But if you notice in that table, I didn't highlight it, the percentage of non-response was much higher among older adults. We don't know why that non-response was higher. It could be that they're LGBTQ, but don't actually want to identify. So there's a number of different issues, but I think that that's a great point. that there, in this relatively short period of less than 100 years, we've seen such a vast increase in the prevalence of LGBTQ people. And I actually think it's only going to keep going up. But I think it's also, I think it's greater recognition of things like toxic masculinity, changing gender norms, that people just feel more comfortable sort of not being defined into these like discrete categories, but also moving across categories potentially throughout their lives.
You know, one more thing you mentioned about policies going across state lines. So where Alabama might have a policy, but maybe it impacts people in Michigan. I just listened to a great podcast with Monica Lewinsky, and she talked about how all young women in the 90s who were watching what happened to her became slightly traumatized by what might happen if they were in a situation with a powerful man. How do you think that that plays out in this scenario where we've got all these states making different rules? Do you think that plays out across state lines and people recognize that Alabama is not accepting with some of the policies that are coming out? So I'm going to be scared up here in Michigan.
Yeah, I mean, I think that's a great, and that's why I brought it up, because I think it's something really interesting to think about. And we haven't considered sort of this like vicarious trauma that exists. I know a lot of people experience vicarious trauma from COVID and from sort of the police brutality. We saw George Floyd, Breonna Taylor, but there is vicarious trauma potentially related to this. I mean, I'm telling you, every time I talk about those anti-LGBTQ youth policies, I literally get chills, and it's not necessarily affecting me directly. I just think that we don't have very good measures of sort of those vicarious forms, although there's some measures for racial and ethnic discrimination. For sort of like, in the media, did you see people like you being treated as like, or being spoken about negatively? I think that we need similar measures to sort of get at how aware are people, even within that state or neighboring states, of those policies, and how much does that impact their thinking around, I'm not going to come out at work because I'm going to be treated differently, or I am going to wait to come out as trans until I'm 18 because I won't be able to get that care. It's a very interesting question.
It is, or you may be too young for this, but Matthew Shepard, when I was in college, what happened to him in Wyoming, how does that, you know, does that scare people? I'm going to change my behavior because of what happened to somebody else.
I'm sure it did. I mean, I think I was in middle school or something when it happened, and it's one of those situations, such a big story, that I think it really impacted a lot of people, and I think opened eyes of people of just sort of the violence against gay men. So I think that there's just so many exciting, although they're horrible, there's a lot of exciting questions that if somebody is a student or early stage investigator, many different ways to sort of go about with this research and move forward. I think it's really an exciting time.
Well, I'm getting the 1 minute note here on my end that we've got to start wrapping it up. Everyone, for those of you that are interested in reaching out to Billy, you can find him at Columbia University if you're interested in reaching out to him by email. And Billy, thank you so much for being here today. It was great to hear all the research that you guys have done. It's very impressive, the amount of information you've pulled together about our 50 diverse states. So thank you for sharing it with us today, and we hope to talk to you again soon.
Oh, thanks so much for inviting me. It was a pleasure.
You
Bye,
bet.
everyone.